Good evening, everybody, and welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Professor Matthew Oliver from Marseille, France. Dr. Oliver did his orthopedic training at both Aix-Marseille University and the Versailles Hospital and graduated with his MD and PhD in biomechanics at the Aix-Marseille University and did a postgraduate fellowship at the Mayo Clinic, Rochester, Minnesota. Dr. Oliver is a professor of orthopedic surgery at the Institute of Movement and Locomotion in the Aix-Marseille University Hospital, Marseille, France. His clinical practice is dedicated to knee-related procedures with a special focus on sports injuries and osteotomies. He's a 2015 American Academy of Hip and Knee Surgeons John Insall Award recipient and 2019 ESCA AOSSM Award Traveling Fellow. Dr. Oliver is a review of the AJSM, the BJJ, and the OTSR. He's involved in the KSSTA editorial board as well. He's published more than 100 peer-reviewed papers with a special focus on basic sciences, sports medicine, and knee procedures. He has presented at over 100 meetings across the world, giving lectures on sports medicine and knee surgery related topics. So today, it's my great honor to introduce you to Professor Matthew Oliver from Marseille, France. Over to you, Matthew.
Hi, everyone. So thanks for the invitation of Photo Evidence to be here and discuss about the current concepts in knee osteotomy. I will try in the next minutes to provide you what I think I do understand, thanks to my partner in crime today, Christian Clay. We designed most of the slides you will see just in this talk together. And I want to acknowledge him to be like my mentor and friend in osteotomy practice today. Let's start. So we're gonna go through this different slides, and of course we're gonna start with the planning of osteotomy and how to assess correctly the lower limb axis and the lower limb alignment. So the first thing you need to understand when talking about the aspect of the lower limb, the position of the leg is very detrimental. And to really truly do a nice understanding on what is supposed to be the angles, the first thing you need to have the patella and the kneecap in the center of the X-ray. In the center of the condyle, you need to have this complete view of the fibula just behind the proximal aspect of the tibia, and you need to have this the two condyle pretty symmetric on the X-rays. Otherwise, you will probably think that here you have a normal alignment, and you can see when you just turn the leg into to have the kneecap in front of you, the femoral valgus is pretty huge with this bowing of the diaphysis of the femur that is just appearing and when you just turn the leg in internal rotation. Other thing, when you know that now you have access to that, you can argue that long axis X-rays are not available everywhere. We just finished a study which is interesting, saying that if you do, the only thing that would change if you compare a scoot view of a CT scan to a long axis X-ray is probably what happened intra-articularly, and for example the intra-articular angle that we're going to define in the next slides. And if the leg is correctly aligned and you have a good way to put the foot at the good position with some 10 to 15 degrees of external rotation and the patella in the middle, the scoot CT scan could be a good option to have a long axis if you don't have access to a long axis machine. Let's dive into principle of correction. This is Draw-Pally analysis in the last, let's say, 20-25 years. First, we need to know what we're talking about. When we discuss about alignment in knee osteotomy, we usually use for the femur the mechanical lateral distal femoral angle, which is the MLDFA. The value of this angle, which is measured laterally, is 87, meaning that you have 3 degrees of valgus inside of your femur. Those measures have been done by Pally and the pioneers of alignment correction with, for most, 40 to 50 patients included. And we will discuss this with our analysis on CT scans. Same thing goes for the tibia. We are measuring the alignment of the tibia and the morphology of the tibia by talking about the medial proximal tibial angle. So it's measured medially, and this angle is also 87 in healthy global population patient, which means that we all have 3 degrees of varus, average 3 degrees of varus in the proximal tibia, and as we described, 3 degrees of valgus in the distal femur. Other angle which is important, the GLCA, the joint line congruency angle, which is here, defining the distal, the articular line of the distal condyle and of the proximal tibia. This angle is usually in between 0 and 2 degrees, and its value will change a lot based on what happened intra-articularly, which can be intra-articular wear on the medial side, for example, and soft tissue loosening on the lateral side, for example. And with the varus getting more and more intra-articular because of wear, this GLC angle will reflect directly the amount of wear and destruction of the cartilage in the subcondyle bone. We call him the nasty one because, to be honest, when the GLCA is increasing a lot, and we will have some case during this talk, for example, to be 8 degree, you will be facing a problem which is mostly intra-articular. And on those cases, osteotomy are not as efficient as their main goal, which is to correct the extra-articular deformities. What we published in this paper this year was that Pali and the pioneers were totally right. And if we just focus on bone morphology on CT scans, you can see here that we were just confirming those values, and we will have an overview of that. It's exactly the same thing for, in fact, for centuries, because if we are with Christian and most of the osteotomy lovers were pretty fond of Johann Mikulic's thesis, which is here. Unlucky me, unlucky for the non-German speaker, it's only German, but Mikulic some 200 years ago already described the MPTA and the MLDFA pretty accurately to be 88 to 89 degrees. So without any X-rays, without any measurement, Johann Mikulic dissect more than 200 knees to find out that the tibia was slightly in varus and the femur slightly in valgus. He also defined the Mikulic line, which is maybe the basics of any planning in osteotomy concept, which is a weight-bearing line passing from the center of the femoral head to the center of the ankle. And without any images, he probably defined all the rules that we are following today in the osteotomies. So if we need to have a plan, let's move it, and let's move there. This is the basics. If we on 700 CT scans, we find out that the MPTA value is 86, MLDFA is 86. External torsion of the tibia is 30. Femoral version of the femur is 20, and the tibial slope, either medial or lateral, is 6.5 degrees. So thinking about that, we all have 4 degrees of varus in the tibia, 4 degrees of valgus in the femur, a pretty externally rotated tibia with an external torsion of 30 degrees, and a pretty anteverted femoral neck of 20 degrees. The tibial slope being 6.5 degrees, either if you measure it as a mean, globally, medial and lateral, or separated, medial and lateral, the mean slope of the tibia is 6.5 degrees. Let's dig in about planning. So I love this sentence from Antoine de Saint-Exupéry, which is a very famous French writer. A goal without a plan is just a wish. And let's dig into planning. So to do a planning, you need to define what is an ideal correction. And once again, we published this paper this year with my friend Romain Sale, Simone Cecello, and Baris Kakoglu about what is the goal in terms of coronal alignment in the osteotomy. And we will define this. How to plan an HTO? Basically, you just draw the Mikulic line, once again, passing from the center of the femoral head to the center of the ankle. You then analyze the deformity based on where it's passing compared to the medial aspect of the central aspect of the tibia, the spines. So if it's passing medially, you're facing a varus. If it's passing laterally, you're facing a valgus. Once again, in the global population, you will have a slight amount of varus because the tibia is slightly more varus than the femur is valgus to compensate. So you will have the normal passing point of passing, which you can say it's a Fujisawa native point, for example, is slightly medial, 4 to 8 millimeters from the medial spine. Then you draw a second line. So this is where my line is passing now. This is where I want to pass my line after that. So you define a point, which we call the Fujisawa point, which is the passing, the intersection in between the tibial plateau and the future direction of the leg. And you project yourself measuring where this weight-bearing line is supposed to pass after the surgery. And you define a new position of the ankle, which is the virtual postoperative position of the ankle. You then define a hinge. We are talking about opening range HTO here. The hinge is the rotational point of the osteotomy, where you're going to rotate the distal aspect of the leg around to create a gap and an angular correction. This is how it works. This is a drawing from Christian, I love. So you just put yourself to be the hinge. Your eye become the hinge, and you look at the ankle. This is my pre-op position. This is my post-op position. And this is where the correction occurs, the angle in between those 2 points. So when you are looking through the hinge standpoint, you can define which is the good correction. So then you draw a line from the previous position of the ankle to the hinge, and a second line to the hinge from the postoperative correction you want to create. This angle A and this rotation is the osteotomy to create. You measure this angle between the line A and line B, and this angle would be reported as an alpha angle into the proximal aspect of the tibia. We're going to define how. This wedge creating and this gap creating will shift the leg from the A position to the B position. And this is how we do an osteotomy. So measuring this height, the alpha angle projection on the medial cortex, you define how the osteotomy is supposed to be opened and to create, if you have the good hinge position and the good entrance position of the saw, creating this H opening, you create the correction you intend to do on the planning. Let's talk about planning. So this is Christian Clay doing a high tibial osteotomy with planning with these hands. So you can see here that we first measure so we first draw the Mikulicz line, which is passing 5 degrees to medial. We then define what is the tibial plateau. We define which is the MLDFA 99, MPTA 80, no intra-articular deformity. We are trusting a second line, and we are now defining the planning of our HTO, which is a correction of 16 degrees. I will stop here a little because the movie is pretty fast to be done in a old-fashioned way. What happened in this drawing was that, so we measure the angle of the MLDFA, which was 89. The tibial angle was 80. And in fact, the correction we need to report to have, for example, the Fujisawa point, which is the passing point of the virtual Mikulicz line post-op of 5, for example, 55, was to do a correction of 16 degrees. And we do think that 16 degrees is not a good correction for a single bone, because you will push the boundaries from 80 degrees of PTA to 96. 96 in our CT scan analysis never exists. It's an impossible anatomical morphology. So if you have something like that and you need to push to 16 degrees your tibia, which is at the beginning slightly in varus, you probably have a big mistake on your planning. And this is why you will redo it and analyzing what happened. So you can see here that the opening is supposed to create is something like very big overcorrection with 10 to 15 openings. So the idea is to distribute, because if you think about it, you also have some deformity on the femur. So how to do that? If you are doing it freehand, you start to get crazy, because you're supposed to cut and reposition and then replan. If you want to do a double level osteotomy correction, measuring and planning with your freehand, you need to cut the paper into pieces and to recreate deformity. So here what you have done, and we'll discuss that at the end, is you have a 1989, which is 2 degrees of varus in the femur. He corrected to be 6 degrees of valgus sorry, a correction of 5 degrees. And then he is redoing his correction, his measurement with the Mignacci technique with the 2 lines, pre-op, post-op Mikulicz line, and then he's measure what he's supposed to do. And this time, you find out that the tibia will be 10 degrees. You can say that it's pretty normal, because you have 16 all in the tibia versus 5 plus 10, which is, of course, quite a similar correction. This is what we've done for years with papers, rulers, and angle drawings and everything. This is now what we've done. If you just imagine, it's exactly the same planning, but with a trauma cut software. So I'm putting first measuring my angle, MLDFA. This is HK angle, so we got 10 degrees of varus for this SHAP. Then we're going to measure the angle of the proximal tibia, the MPTA and the LDFA. So my MPTA is 75, which means 10 degrees of varus. Then my MLDFA is, I need to move this a little bit, is 87, I think. So completely normal angle, so 87. So for this patient, the angle correction is the 10 degrees of varus we have on the global lower limb alignment is defined exactly by what happened in the tibia. So then I will do my Mignacci. So I'm drawing the first line, which is the Mikulicz line. Then I'm defining a second line, which is the line of the virtual correction. The only question we need to answer at this time is where I want to put my future passing point on the proximal tibia. There is tons of paper on that, and nobody get the answer. It's going from 55%, which I'm doing here, passing on the top of the lateral spine, to 60 to 65% correction. In fact, I will say that it will be highly depending on the situation you want to correct. If you have no more meniscus on the medial side, if you have very bad cartilage deterioration, if you are facing a young patient with a salvage procedure, probably you want to push the valgus a little bit further. But if it's a very normal early arthritis, normal meniscus, only small amount of convexity on MRI, a 50 to 55 correction, which is normal access to 55, which is a slight amount of valgus, will be enough. So the idea is to measure the percentage of this is 100%, the full length of the medial plateau. 55% will be something here, 60, 65, 80, 80, 90, and 100%, of course. So knowing that, what I'm going to do is doing my Mignacci. So I got my line here. Once again, it defined the previous position, the pre-op position of my ankle, the future position of my ankle. And then what I'm going to do is, starting on my hinge, I will draw 2 lines, a line A and a line B, which connect those 2 angles, so those 2 ankle position. So the correction I need to do here is 13, maybe a little bit less because there is some, so 12-degree correction to have something passing from a line A to a line B in this patient. So once again, how I'm defining the position of my Fujisawa point is only based on what I want to treat technically. Here it's a 55. So then let's restart this one. Then I'm defining how to cut my proximal tibia. The ideal cut in terms of position, metaphyseal to diaphyseal, is to have a 110-degree cut when you do an angle with your here, so your sewing cut, the sewing plane, and the lateral aspect of the tibia. This has been defined by Matt Dawson some years ago. This is the ideal position of the cut. Then once you do that, you just have to move the second line and to create the 12-degree correction you're intending to do. So this is what happened when I'm doing a 12-degree correction. I'm gonna put up my proximal tibia on my cut. So I will create a wedge here of 11, 12 degree, whatever I want, and measure the height of the opening I will be creating to do that. And this is what we call, this is the final aspect of the osteotomy. So I'm just measuring what I'm supposed to do here, done. And it's, I'm supposed to create 30 millimeters to create 11.3 degree correction, for example. And this is the only real thing I need to know regarding the planning of my osteotomy, this 11-degree correction. So, but if you think about it, this one, so we imagine Christian was doing the edge correction. This is the 2G correction, and we switch into the 3D correction. It's exactly the same patient with the pre-op. And you can see here that I'm doing the same thing. I'm measuring. You can see I got an 86, 80, 87, and when thinking about that, I just discovered that when I'm doing a CT scan and a planning in 3G or 3D. And you can see here that we have what we measure. The MPTA was 79, MLDFA normal. But what we find out is this guy got also a very abnormal slope with 14 degrees of slope. And it also have an external torsion of the proximal tibia of 47, with normal being 30. When doing that, the question is, should I correct everything or should I only focus on the varus? He is 26, he is painful in his daily life, and for him, I intend to correct everything. I also define which will be my ideal cut to do that. So it's a very pretty low osteotomy cut here to correct at the same time the slope, derotate, and correct the varus of 10 degrees. So we got a 10, 7, and 20-degree correction for the torsion, which is what have been done in the same time. And to do that, I switch into a patient-specific cutting guide to do hallmark correction. We're going to discuss that in the next slide to have all in one. And this gave me a personalized guide. This gave me, the position of my keywire, the length of the screws and everything, and we're going to discuss that. So this was a 3G planning. Let's move into the 4G planning. So I did this yesterday with this is PicMed, which is a software that I love. You can see here that I'm going to measure I'm going to first calibrate my image. It's not the same patient, but it's the same process. So this is a 20 millimeters, and I switch into this image. I'm going to create a procedure, which is a left side knee osteotomy, or right side knee osteotomy, sorry. So I'm using this magnifier to put some points: center of the femoral head, external part of the femoral head, top of the greater trochanter, distal aspect of the medial condyle, distal aspect of the lateral condyle, the proximal aspect of the medial plateau, proximal aspect of the lateral plateau, more lateral point of the lateral plateau, more medial point of the medial plateau, lateral aspect of my talus, medial aspect of my talus. And then all the measurements are done automatically, which is pretty cool. So you can see here that it's gave me that I got mostly a deformity, which is a tibia, in a normal GLCA, a normal MLDFA. So now I'm asking the software to create an HTO procedure. So I'm defining my cutting plane with 2 points, and then I'm selecting the weight-bearing position, so the Fujisawa point, and I will say I want to have 60. And the software is creating the osteotomy itself and giving me the measure I'm supposed to have here, a distance of 10.7 millimeter inside of my osteotomy gap. This is the 4G, and now we get the 5G. So this is the 5G measurement, which happening here. We are working on that. So it's a fully automated software. I'm going to shoot the video. So sorry for the French. We are just so it's a fully automated software asking you to provide a long axis X-ray. We just go into the it's a fully automated algorithm. You just select the X-ray you want to have. Let's of course select this one. We want to do a left osteotomy, and you launch it, and the software is calculating everything based on IA creation on more than thousand long axis we already defined, and the software is giving you the answer. So it's done. You are of the measurement you need to perform your osteotomy. And you can see here that we select arbitrary one of the long axis, and the answer is you should not do anything because the distal femur and the proximal tibia are 100% normal. So this is the, and of course, sooner or later, you will be able also to do the osteotomy, the auto-osteotomy, and giving you everything you need. So this was for the planning, and now let's think about the specificity of high tibial and distal femoral osteotomy. So you can see here we discussed a little about this Fujisawa point. You can see that this paper of Fujisawa on 54 arthroscopic analysis on the weight bearing on tibias some years and years ago. I think it's in the early 70s. You can see that it's the suggestion of Fujisawa was to switch the weight-bearing line to a 30 to 40% Fujisawa point position. And this has been debated, but it's pretty large. It's a pretty large zone from 60 to 70%. And at this time, remember that they were treating crazy cases like this with very bad arthritis and very huge correction. So for this surgeons facing early arthritis without any total knee arthroplasty or unique compartmental knee arthroplasty on the market, this was the gold standard procedure. And Frank Noyes, some years ago, you can see here that they recommend the 62 to 66. So they narrow the window defined by Fujisawa. But once again, totally arbitrary decide that the point to be selected was 62 to 66. Which come into what come to me as a new thing some 4 or 5 years ago, meeting people like Philip Lobanoffer, Ronald Barney-Warden, Christian Clay, Adrian Wilson, I mean, the highest level surgeons in knee osteotomy in the world, was that we cannot create a massive abnormality just for the sake of mechanics. And this is what we are doing every day. If you have the goal of osteotomy should be to correct an extra-articular deformity. You have two main objectives. The first one is to do something which would please the mechanics of the knee, shifting the load into a normal compartment. And the second one is to correct anatomy into something which is close to the healthy subjects. The healthy subject rule would be to have a normal MPTA. Normal MPTA is in between 84 to 88. Normal LDFA, 85 to 90. For the sake of mechanics, you cannot push anatomy too far. And if you're planning an osteotomy, thinking that having an MPTA of 95, 96 at the end of the surgery would be a good option, I'm going to show you how it's not. So if you creating something like that, this is what will happen. So this is not a case of mine, but it's a case I was interviewed for what happened to this guy. So this guy got a 40 degrees of varus, MPTA 85, MLDFA 92, GLCA 7. So where are the problems? So you have, of course, a bowed leg with 40 degrees of varus. But if you look closely, 2 degrees of varus are in the tibia, 5 are in the femur, and 7 are intra-articular. And what was decided was to correct everything in the tibia. And you can, just looking at this leg, you can see that the joint line is completely insane. First, there is a complete oblique joint line, and second, there is a massive it's like a sheath-free fracture because of the opening. The opening was probably too big for this poor tibia. You need to understand that doing that, something what was wrong at the beginning was that the main deformity was in the femur and intra-articularly. This guy should be a good case for a total knee arthroplasty, of course. Might be a good case for a combined DFO plus unicompartmental arthroplasty, or if you really want to do no prosthesis at all and shoot to an osteotomy, this is the case for a double level osteotomy with a small correction on the femur, small correction of the tibia, and we're going to discuss about that. So double osteotomy became more and more frequent in my practice for a reason pretty obvious. I just follow those. First, it's going to give you the best results you have in literature. Double osteotomy is a 96% survivorship at 5-7 years, even in the end of the early pioneer surgeons, such as the Mayo Clinic surgeon that did this study some years ago. Second, not everything could be addressed in the tibia. If you look, the joint line is a very important point. You are not treating patient with a CORA concept. You are treating patient with two bones and a joint line. So osteotomy will correct extra-articular deformity, and what happened inside of the joint is a reaction of this correction. And you need to think about that when you do osteotomies. Because you can see in this patient, that if you intend to do a full correction of 19 degrees to have a correct Fujisawa point at 55%, you create something very inaccurate, which is an MPTA of 100%, 100 degree. 100 degree never occur in normal human beings. So we should not create things like that. Otherwise, what will happen is you have a very oblique joint line, which is create shear forces on the lateral and medial cartilage and probably alter a lot the results you will have with at a short time frame. So what to do on that, of probably first do a shortcut and a short correction osteotomy. Then when this osteotomy is done, the joint line, the weight-bearing line will be closer to the medial spine, and you can do a short osteotomy on the medial aspect of the tibia to correct this insane intra-articular wear. One may argue that it's not a case for a good candidate for osteotomy. I would say, yes, you're right. It's a good case for a total knee arthroplasty. When you're facing a young, high-demanding, active patient, we all know that TKAs are not a good solution for that. And in this case, I would rather do a double level osteotomy, preparing the patient and telling him that it's a very good option for maybe a decade, and he will have a total knee arthroplasty after that. But those 10 years will be better than the one he will spend with a TKA and a revision TKA after 10 years. I would say that the success of HTO is based on the two things we discussed: indication. Indication, for me, it's very easy to define. The good indication for an HTO and DFOs are substantial metaphyseal deformity. If you only do surgery in patients with substantial metaphyseal deformity, either on the tibia or on the femur, you will have only good results as long as you do a good job doing the surgery. Any other indication are borderlines. If you intend to create intra-articular correction by extra-articular osteotomies, you're doing a mistake. The only thing that will happen is a consequence of the knee osteotomies, the tibia or the femur or the double level osteotomy will influence the mechanical behavior of the knee, but it's an indirect thing. It's not a direct thing you do like you do a TKA intra-articularly. Planning is 20% of the game. So I think you had a lot of planning already, and then comes surgery. And what is specific in terms of surgery? There is only two things: a sewing plane and a hinge position. As you can see here, that the position up and down is not influencing a lot the amount of correction you're creating. But what is very influencing that is the position around the clock. So if you do a cut which is exactly parallel to the slope, you're not to the proximal aspect of the plateau, you're not influencing the slope. But as if you turn in around the clock the position of your slow blade, even by 5 to 10 degrees, you are completely modifying the slope. Other thing you need to know is the position of the hinge. The position of the hinge will deeply influence the value of the slope at the end of the surgery. And you can intentionally create a corrected or exaggerated slope if you are facing patient with abnormal slope value at the beginning. The global idea is if you have a very posterior slope and you're inserting the wedge or opening the wedge at the exact same position, you can pass from a +6 to a -6 slope just because the rotational point of the osteotomy is more anterior or more posterior on the proximal aspect of the tibia. If you don't want to change the slope at all, the best spot is in the middle of the tibia, in between the girder tubercle and the femoral head. But if you move more anterior or more posterior and you insert the wedge at the exact same position, you are changing the slope at the same time. But you can also intentionally do it. You can see here you have a reverse slope correction to do. So we're just moving anteriorly the slope, or an excess of slope, and we're moving the hinge posteriorly to change this. The global idea around that and this what happened to me in 2016, understanding that those two detrimental points, the sewing plane and the hinge point, were very, very complex to define freehand. We decide to define them with a new system, which is a patient-specific cutting guide. And we start doing that in 2014 with, I've done my PhD on that. And the idea was to have a system to position a hinge, to drive a sew, and to define a 3D correction. And if starting with that, we can move into something which is safe for the hinge, time sparing for surgery, allowing to do additional procedures or going to crazy stuffs, I think we will have done something good for all surgeons and for all osteotomy procedure. So what happened is in 2014, we start with this new toolbox. December 2015, first case. You can see on this one is that basically you have this cutting, this PSI toolbox with two key wires. The first one will drive the saw blade. The second one will protect the hinge. This one will help to have to drive the saw blade, and then you're creating some holes on the this PSI that will be on the tibia at the end, free. And what will happen when you do that is the holes are not matching the plate, and the reason for that is it's already pre-measured, and when the hole will be facing the plate, the correction you want to done will be complete. So this system do three things: creating the ideal osteotomy, sewing plane, hinge position, then giving you some clue to create your correction based on the hole you're drilling, first on the PSI, and second, you will have on, because it's the screw holes on your plate. The matching process in between those two elements giving you the correction. And it's also that you can imagine that this first key wire, at the beginning, we just had it into the PSI to enhance the securization of the PSI onto the bone. And at the end, as you can see here, it's also, we discovered that first, it was stopping the saw blade from cutting the hinge, which was cool. And second, you will understand that it helps to do something else. We published many papers on this technology. My favorite one is probably this one on learning curves. And you can see that only after 10 cases, you completely demolish the time you need to do an osteotomy into 25 to 35 minutes. You're only taking 6 X-rays compared to the high number we had before this technology. It's accurate because the precision of the system was published already, and is something around 1 degree for HKA and zero 0.5 for MPTA and LLDFA, and it's published on Kesta last year. We have some complication, of course, and you can see here that hinge fracture, Takashi 1, 2, and 3 were very frequent before we had this Keywire inside of the system. And now the main complication we had at this time was problem with graft. We were using phosphocalcic cement at this time, and we have some issue with cement persistence inside of our PSIs. Hinge fracture, terrible. I mean, when you start doing a lot more and more osteotomies, it is the main problem. We have three types: type 1, type 2, type 3. The worst for me are type 2, which are this one, the type 2 fracture, getting below the femoral tibial, the tibiofibular joint. And this is a Takashi 3, for example, getting into the joint. And you can see here that this technology, this PSI technology, provide us a nice solution to avoid Takashi 2 and 3, but not Takashi 3. I think today that Takashi 3 fracture are mainly occur because you are not protecting, you're afraid to cut the posterior aspect of the tibia, and you create an opening without having a complete cut of the posterior aspect of the tibia, and you're just cracking into the joint because of that. We publish our strategy on that, first with hinge key wires, and today with hinge screws we are using in our daily practice. You can see here that we are putting some screw inside of to protect the hinge postoperatively, and we are just moving forward and forward to have more tools than those described by others, such as these hinge key wires, which we described in 2015, are now used all around the world. This is an Australian surgeon giving a talk for Isacus some months ago, exactly doing the same thing. I think this hinge key wire is already spread around the world, and this hinge screw concept for weak hinge, like in this one. So this one was a 17 closing wedge in a ODI disease. This is a double level osteotomies where I'm protecting a lot, and for this case of post-traumatic complex thing, we are doing this more often now, and we publish some papers on that to validate the concepts. Time sparing, you can see here that my cutting this PSI technology also allow you to have information regarding the screw length, the position of the plate, and everything will be pre-measured prior to the surgery. When I'm starting a PSI cases today, everything is on the table. Screws, plate, key wires, whatever, is already ready. So I don't have to ask for a 15, 45, 50 screws. Everything is pre-done on the table before I start, so I earn some minutes there. Additional procedure, you can do an ACL plus osteotomy with this technology, and you can see you have an additional cutting guide, a drilling guide to do your ACL tunnel, and to be sure that you are not touching here the screws with the tibial tunnel. It's really helpful at the beginning when you don't have a huge experience of HTO plus ACL. And I'm still doing most of my posterior opening plus ACL surgery with this technology, because it's very bothering when you're eating your osteotomy screws with the tunnel. And you can see here the safe spot is not so big if you want to target this zone. If you're too anterior, too posterior, or too divergent, you will touch your screws for sure. And we published that in arthroscopy some 2 or 3 months ago. Femoral specificity, not so big. I mean, the key wire need to be we have key wire to protect the hinge and to do the cuts exactly the same. We have this, the plating is not the same, but it's working exactly the same way, and we are enhancing the resistance of the hinge with this screw to avoid secondary cracks that occur more often in femoral osteotomy than in tibial ones. Several paper was published on PSI technologies, and if you want to go into literature, you will find a lot. And I think it's now getting one of the main option you have. My first one was 3 years ago, 27 years old, posterior osteotomy, opening wedge, 7 degree. You can see that it was a very straightforward, pretty obvious case. And one of my last was this one, motorcycle accident. We need to do a 17-degree frontal correction, 5-degree slope, 20-degree torsion correction at the same time. So tough. You can see that the cutting guide is not looking exactly the same way that before. With two windows, two frontal window, one horizontal window to correct the osteotomy with a small wedge, which will be resected to allow the torsion of the distal tibia on the proximal one. This is the final X-ray. Last thing I want to discuss with you, what about the most feared complication in knee osteotomy? Postural vascular structures complications. We thought a lot about that. We published an arthroscopy technique on that, and this is the last version with Christian Clay doing the surgery in London of our understanding and our protection of the neurovascular structure. So a straightforward mini incision, it's Christian Clay, so it's a very small one, and you can see that we have a protector that will insert behind the MC, the posterior oblique ligament, and this protector through the same window will get behind the neurovascular structures, will be fixed by two key wires here, and this thing will be stuck. When this key retractor is inserted, we are starting to release the posterior oblique ligament here. This allows us to define the position of our cutting key wire. And we only protect you can see here the pole is nicely protected by this small Hohmann retractor, but the neurovascular structure are protected by this posterior oblique, but this posterior retractor. We do our cut with here it's a precision blade from Stryker, but you can do it with a regular one, you just in the bigger incision. So we do that. We do our biplanar cut by we remove the posterior retractor to have more space with the mobile window. So we do our anterior cut, and then the opening is doing, you can see here that we have a small system to do the opening of the osteotomy with a laminar spreader with those two small BB key wire that Artrex called them the BB key wire, but it's not Artrex one, but anyway. So we put those two, one proximal and distal to the proximal aspect and distal osteotomy. And in fact, we are using the laminar spreader on them to have the complete access to the gap and to insert a bone wedge without being locked by those spreader. The laminar spreader we use today are calibrated, so you know exactly how much you need to open to create an X millimeter opening. So for example, here it's an 8, and then we are sculpting a bone wedge for the exact size. We are inserting it to lock the osteotomy in the good position. We'll have some X-ray for that. And once this is done, we are putting the bone wedge inside of the osteotomy site. The osteotomy can be fixed by itself. So you can see here on the X-ray that the osteotomy site is completely filled. We can remove the laminar spreader, and we can remove the 2 BB key wire. We are just watch at this time when you need to measure with a rod alignment that the correction is correct, and then you can put your plates on because everything is fixed, and you put your plates on and your screws, and the surgery is done. Last thing I want to discuss with you was what about the post-op regimen? A lot of people are not doing osteotomy because they don't want to say to patient that they are just cutting their leg into 2 pieces and recreate something with plates. This is not what I'm doing. I'm telling patient that I'm creating an incomplete fractures with a saw, which is a perfect cut. Inside of this fracture, I will put a wedge to correct the angle, but there will always still a safe spot, which is called a hinge, which allows rotation. Doing that, I will fill the gap with a femoral head allograft. This allows me to do outpatient surgery because it's not bleeding at all. This allows me to do full weight bearing day 0. And you have here a patient at 3 weeks post closing wedge tibial osteotomy. You can see that I'm asking him to do whatever you want, no bullshit, 3 weeks, standing on the osteotomy site with 1 foot, no problem with that, because I'm confident on my plate, my bone feeling, and I'm always closing when I'm doing a distal femoral osteotomy, so I'm very confident on that. I think the other things that change our practice is tranexamic acid. So I'm doing tranexamic IV for every patient, and this really allowed me to decrease the number of hematoma I had at the beginning of my practice. I was say regarding femoral head allografts, most of the people asking me how I'm doing that. I just have a femoral head and I'm cutting this with my saw, measuring with a ruler the height I want to have on my wedge on the medial side of it, and then inserting it inside of the tibia. I think we are done, and I want to thank you for the opportunity to discuss about osteotomy. I'm happy to receive anybody that wants to come and visit our department. We have pretty often La Patrouille de France, which you have on this picture, to visit us. And if they can come, maybe you can be on the Alpha Jet with them and come and visit. See you, and I'm happy to answer questions now.